Good evening and welcome everybody. Thank you so much for joining us. A big warm welcome to all of you. We're going to be talking about eating disorders today and hope you'll find it useful and helpful. So my name is Jamil Boss and I'm the Principal Psychotherapist in the Sussex Family Eating Disorders Service. I'm a family therapist and I've worked in eating disorders now for almost 7 years. My interest is in the impact that eating disorders have on families and supporting them to use their strengths and resources to help their young person recover. I'm going to hand over now to my lovely colleague Zoe, who's going to introduce herself as well.
Hi, good evening. I'm Zoe. I'm the lead nurse for the Sussex Family Eating Disorder Service. And I've also been working with children and young people with eating disorders for around 7 years. Along with being the lead nurse for the team, I'm also an eating disorder therapist and I work with families supporting their child in their recovery.
Right. So Zoe and I work for the Sussex Family Eating Disorder Service. We are currently commissioned to treat 2 major eating disorders, namely anorexia nervosa and bulimia nervosa. We work with families with a young person suffering from anorexia or bulimia between the ages of around 10 and 18 years old. And over the course of the next hour, Zoe and I are going to talk about what eating disorders are, about some of the different types of eating disorders and how they may come about. We're going to then talk more specifically about anorexia and bulimia, as these are the 2 eating disorders that we have the most experience with, followed by what to look out for as parents and also what to do if you're worried about a young person in your care. Finally, we're going to also touch on the treatments that we use in our service, as well as some strategies and tips for how to begin helping your child recover, both while you're waiting for a service and also if you are currently receiving a service from us. So we know that eating disorders are serious medical conditions and they can put people's lives at risk. They're characterized by disturbances in thoughts and emotions around food, which then manifests in disturbed eating behaviors. We also know that eating disorders cause a huge amount of distress to the people who are suffering from them and also on their families and other people who care about them. They are also notoriously difficult to treat. So I'm going to just have a look briefly at some of the figures from the NICE guidelines to give you an idea of the prevalence of eating disorders and also a little sort of idea about sort of the impact and the risks of them really. So NICE stands for the National Institute for Health and Care Excellence, and they provide a set of evidence-based recommendations for health and care in England. According to the NICE guidelines, over 700,000 people in the UK have an eating disorder, and around 90% of these are female. We do also know that this is probably likely to be an underestimate, as not everyone with an eating disorder will present to services. And this can be for a range of different reasons, stigma, shame, people potentially not feeling like they can give up the eating disorder, and so on. We know that eating disorders can develop at any age, but for anorexia nervosa, the first onset is most likely to be in adolescents and young adults. So mainly between sort of 15 and 19 years of age. So we also know that this is the group most at risk. Bulimia tends to develop on average a little bit later, but obviously can develop at any age, but usually sort of we're looking at sort of from adolescence around 17 up to 25 is the usual onset. If you're interested and want to go and have a look at the NICE guidelines, they are online, you can Google them. So if you just Google NICE and then eating disorders, the page will come up. And there's lots of information in there about what they are, about all these statistics that are on this slide, and also a little bit about what evidence-based treatments there are and what recommended treatment is. So these are some of the different types of eating disorders. I'm not going to go into too much detail about them now because Zoe's going to talk more about these in a moment, but this is just a kind of a brief overview, really. So as I said before, the figures on the slides are taken from the NICE guidelines from 2019, so that's when they were last updated. The lifetime prevalence on the slide refers to the proportion of a population that at some point in their life has experienced a particular health event. I think the thing to take out of these statistics, the salient point here, is that while anorexia is is not particularly common, it has the highest mortality rate of any other eating disorder, and it has the highest mortality rate of any other mental disorder. And so that is the reason that we know that eating disorders need to be taken really seriously and treated as they would any other serious illness. Before Zoe goes on to talk about specifically anorexia and bulimia, I'm going to just briefly touch on etiology. So etiology refers to sort of causes or things that might lead to an eating disorder developing. And we know that people often want to know why their young person has developed an eating disorder. And obviously it's understandable and natural to think that if you know the cause of something, that this will help you know how to address it and reverse the eating disorder. However, eating disorders are complex, and it's usually not possible to identify specific causes. Rather, research shows us that some people are genetically or may be genetically predisposed to developing an eating disorder. And you are possibly going to be at higher risk if someone in your family has or has had an eating disorder at some point in their life. This genetic predisposition to an eating disorder sort of then interacts with environmental factors. So we all sort of go through difficult times in life sometimes, and we can't necessarily control what happens to us. But we speak about triggers being environmental factors. Some examples are things like bereavement or family breakdown, friendship difficulties, perhaps a young person has been bullied at school or is being bullied. We also know that, young people have, are quite astute at knowing what upsets other young people. And so, calling somebody else fat or commenting on their body is kind of is a good way to upset people. And, lots of kids will know this. We also live in a diet culture where, talk about food and bodies and appearance and what we should and shouldn't be eating is a factor of modern life, really. None of us can really escape that, and it definitely classifies as a trigger. Other difficulties such as social media influences, which is kind of fairly new in the last few years. There's been a proliferation of people online who promote different diets, different types of exercise, ways of eating, kind of post pictures of skinny bodies, etc. And so for young people who spend a lot of their lives online, that is going to be a big factor. The other thing that we hear quite a lot from families when we are sort of doing assessments is that healthy eating talks at school can also be a trigger. And for some young people, hearing about what they should and shouldn't be eating can be quite worrying. However, it is worth remembering that lots of people are exposed to these things and they don't develop an eating disorder. This is important to remember as we don't find it helpful to pinpoint blame. And we know that eating disorders are certainly not anybody's fault. They're not the fault of the person suffering, and they're certainly not the fault of parents either. Conversely, we find it far more helpful to focus on what might be maintaining an eating disorder and to work towards recovery rather than trying to sort of retrospectively on identifying a cause. And we are going to go ahead and say a bit more about treatment later on. I think the other thing that's worth mentioning here is that it's important to note that eating disorders affect all types of people from different socioeconomic groups. They don't discriminate. So there is this idea that predominantly white girls from middle class families are suffer more than anybody else from eating disorders, but actually the research figures don't bear this out. And we know that different ethnic groupings have pretty similar sort of representations of how many people might suffer. I think there is some research to do and a bit more work on our part to do about potentially why people from different ethnic groups may not present for treatment. Similarly, we see predominantly more girls in our service than we see boys, but the numbers are on the increase in boys. We suspect that the incidence in boys is probably higher, but due to stigma and probably some preconceived ideas about eating disorders, boys are a lot less likely to present for treatment, and the symptoms in boys are also more likely to be missed. So, for example, a boy might be more likely to present with a preoccupation with exercising and developing muscle, or wanting to get very lean for a specific sport, such as running, say. And there may be the belief that being very lean will improve their running or cycling times, for example. So we know that intense interest in sports may be masking an eating disorder for a boy. And even if it doesn't start as an eating disorder, we know that when people restrict their diets and lose weight, that increases the preoccupation and intense interest in food and body anyway. So it can also trigger an eating disorder. Okay, I'm going to hand over to Zoe now, who's going to talk a bit more about anorexia nervosa, what it is and what to look out for. Over to you, Zoe.
Thanks, Sharon. So, looking at anorexia nervosa, it's for anorexia to be diagnosed, in addition to the weight loss, a person will typically be highly preoccupied with their body and over-evaluate the importance of weight and shape as a priority in their life. There's typically a distortion in body image, with sufferers believing they're overweight or a normal body size when they are actually very underweight. Ironically, this may become worse with increased weight loss, as the staff brain is more likely to be cognitively dysregulated. We therefore find that the more underweight a person is, the more unhappy they may become with how they look and the more afraid they are of gaining weight. Their thought becomes very rigid, very black and white, and that's quite common in this presentation, feature of this presentation. We have, when we talk about low weight, we don't use BMI in children and adolescents. That is for over 18s. We use a ratio called the weight for height ratio. And that's because we know that for children and young people, their weight is kind of a moving target, really. They should carry on, gaining weight all the way through their adolescence, whether they're underweight or not. And a healthy weight for height ratio is generally between 95% to 105%. But that's the general, the average, whereas, you have healthy adolescents above 105 and some below 95, although that's not as common. There's the restricting type, and there we also have the anorexia purging subtype, as you can see from the slide there. So the physical risks of anorexia nervosa, there was an experiment done in 1944 on a group of conscientious objectors by Ansel Keys, and it offered insights into what happens to a person when they're starved, even if they didn't have an eating disorder to begin with. As World War II came to a close, troops making their way across Europe encountered towns and cities that were filled with starving people. Scientists knew very little about the effects of starvation at the time. Ansel Keys at the University of Minnesota rose to the task of finding out how starvation impacts the body and the mind, and how to devise a most effective rehabilitation strategy. So he devised an experiment to starve the participants. So for 3 months, the men were fed 3,200 calories per day, and then followed by 6 months of a lower calorie diet of 1,800 calories per day. The goal was for the men to lose 25% of their body weight. And the men were also expected to walk a mandatory 22 miles a week. They were subjected to vigorous tests and measurements so the scientists could gather data about their physical, mental, and emotional state. The effects of starvation was astounding. Physically, the men appeared gaunt with sunken ribs and gaunt faces. Their extremities were filled with extra fluid or edema. A few started losing their hair. Their energy levels dropped and they experienced dizziness and loss of coordination and even ringing in their ears. The men's interest in women and their sex drive all but disappeared. A few developed depression despite never having experienced those feelings before. Most interesting of all were the men's behavioural changes. Despite lacking disordered habits before the study, all the men became obsessed with food. Eating became a ritual. Some would water their food down so it would take longer to eat. Others would simply lick their plates clean. Some collected cookbooks and would find pleasure in watching others eat. They became increasingly irritable and moody and sometimes lashed out at people at mealtimes. Rehabilitation proved to be the most difficult part of the experiment for some. For 3 months, they were prescribed diets which slowly increased their calories. For many, their weight continued to stop despite eating. Their weights continued to drop, despite eating more food. The men reported to feel dizzy, apathetic, and most of all, incessantly hungry. Even after rehabilitation, most men reported not feeling back to normal. Some men stated that it took nearly 2 years to recover physically and mentally from the 6 months of starvation they endured. Follow-up studies showed that the men weighed more and had more body fat than before the study started. A few men expressed concern about their post-weight restoration bodies and weight distribution, stating that they felt much fatter than they did before the study started. This study explained a lot about the effects of starvation on the body. Much of what we understand about today can be tied back to the results of this study. We now know that starvation, whether voluntary or involuntary, is extremely taxing on the physical self. We also know that even people who are at a healthy weight and not inclined to disordered eating become obsessed with food and eating when they're deprived of adequate nourishment or subjected to restricted eating. So we can understand from this that starvation itself can trigger or perpetuate the symptoms of anorexia and make it harder to recover. It was also interesting seeing how the men viewed their bodies as well, even though, at recovery, it showed that those kind of thoughts and cognitions had taken a while, were still being shifted. They were still quite rigid even after physical recovery. So within our girl population who are suffering from anorexia, one of the most concerning parts is the amenorrhea, so the lack of periods in young girls. We're concerned about this because of the long-term effects on their bone health. The hormones that feed periods also help to lay down the bone strength. We all have a window of growth bone growth up until the age of 25, and then our bones stop growing and there's no more opportunity to add bone. If a young person has not had a period for more than a year, they are at increased risk of osteoporosis, and we recommend a DEXA scan to assess any potential delay in growth. Muscle wastage includes the heart and the brain. When the body fat has been depleted, the muscle is used as an energy source. When the heart is smaller, it has to work harder as it is under more strain, and this causes a slower heart rate, low blood pressure, dizziness, fainting, lethargy, and feeling extra cold. The metabolism slows down to conserve energy, and this can lead to constipation and the slowing of food through the gastric passage. The stomach muscle is also smaller and weaker, and the young person is more likely to feel bloated and full very quickly. The body shuts down other long life-sustaining functions, such as sending nutrients to the skin and the hair. The hair gets much thinner, and the skin becomes drier. Parents might notice an increase in hairiness on the arms or the back, which is called lanugo, and it's kind of that soft downy hair. And this is an attempt for the body to try and keep itself warm. People will often suffer with insomnia, and this comes as a result of a survival mechanism of the body trying to keep the person awake in the hope that they will go and get some food. Okay, so we have a picture of the brain here, and we have on the left a patient with anorexia nervosa, and on the right is a picture of a healthy brain.
We have on the left from the web. Take a look.
Sorry.
Not sure what that was.
No.
So the brain is smaller with the person with anorexia, and there's more kind of gaps in between the brain matter. And a healthy brain, you can see, is much bigger. So we know that the brain actually physically shrinks when somebody is really malnourished. The neurotransmitters will be disrupted. Dopamine and serotonin are responsible for keeping the mood stable. So cortisol and adrenaline will be much higher because starvation is perceived as a threat. So the child might be feeling more anxious. However, sometimes the starvation also dampens down those emotions, and they may present as feeling very flat and not concerned. The part of the brain which is primarily affected is the prefrontal cortex. This is the logical part of the brain, so some of the irrational thoughts will be to do with the effect on the weight loss has had on the brain. The child will be operating from the limbic system, so they will have less control over their emotions and behaviours. And parents will often talk about how their child's behaviour is very different to how it used to be. There may be much more challenging behaviour. There might be swearing and shouting and physical aggression. And we know that these behaviours are as a result of the brain and how it's functioning. The good news is that the changes in the brain are reversible once adequate nutritional intake has been restored. But it isn't uncommon for the psychological changes associated with thinking and the behaviours to take much longer to recover than the weight restoration. So here we have a picture of a healthy heart and the heart of a young person or a person with anorexia nervosa. The picture on the top is a healthy heart, somebody that's recovered from anorexia, and the one below is, you can see, a much smaller heart. A smaller heart means it has to work extra hard. It has to work really hard at pumping the blood around the body, and that's that's why we see the effects to the blood pressure and the pulse rate. So looking at the mind map, there are many psychological effects of anorexia nervosa. Behavioural changes, as I've said, will be noticeable. They may become more irritable than usual. They may isolate themselves more, and they're often more secretive, particularly around food and meal times. So the young person might say they'd already eaten at a friend's house, or they might be throwing their food away or disposing of it in some way. And these behaviours are often there, you know, and in young people that are usually very honest, and it's an effect of the eating disorder. The isolation may be multifactorial. It may be due to lethargy and tiredness, or a loss of interest in the outside world. It could be due to an avoidance of having to eat with friends or family, or worries about being exposed to other people eating. They may also feel self-conscious about their body being commented on by concerned friends or family. We also know that young people might regress in terms of what they would normally be doing at that age. So they might be afraid of separation from a parent, and they might not engage with their peer group as would normally be appropriate during adolescence. Education may be disrupted due to needing time out of school in order to recover, or because of difficulty with concentration. If a young person is underweight, they won't be functioning optimally, and they will also be putting further strain on their body. So we advise to stay at home and rest in order to focus and prioritise that recovery. Lots of parents worry about withdrawing their child from school, but we would always recommend doing everything to tackle the eating disorder first. The longer the eating disorder continues or drags on, the harder it becomes to treat, and then you may find education is disrupted over an even longer period of time. Other issues associated might be the development of OCD, which are obsessive types of behaviour. The young person may become more anxious, especially around meal times, and that includes before and after. So we would advise that, you know, even before the meal, there's someone there to support the child or teenager, to help distract them, to keep them busy, and definitely to keep them out of the kitchen, because we know that when the young people go into the kitchen, they're watching what's being prepared, wondering what's going into the food, and it can cause lots of arguments and distress. Obviously, receiving support throughout the meal is important, but also afterwards as well. Supporting them to keep their mind occupied, trying to give some distractions. They'll be experiencing distressing thoughts around this time, so any help they can have to keep busy and keep distracted is helpful. Another really important psychological risk is around the impact on the family dynamics. Clinicians sometimes refer to anorexia as an unwanted guest within the family. And this is one of the reasons why family therapy is the first-line treatment. Whilst anorexia nervosa controls the young person, family members can also find themselves being controlled. And it will also cause lots of friction and distress within family members as loved ones try to support their child to eat. So there might be more arguments than usual, and the impact on this illness within the family is not to be underestimated, really. So the work around the family is there to support that process. In terms of the control, sometimes parents feel tempted to kind of drive all over the country to get the sort of food that they know their child will eat, or the certain bread or yogurt or any of those sorts of things. But this we would advise not to do, to just have non-diet foods within the house, and to plan the meals as you would have done before their child became unwell. So moving on to bulimia, Bulimia is characterised by episodes of restriction, binging, and compensatory activities such as vomiting or intense exercise. As in anorexia, there is an intense preoccupation with weight and shape. Focus on weight and appearance is a high priority to them and will often overrule any other interest they may have in their life. These young people are more likely to be a normal weight, as vomiting isn't an effective weight loss method. The young person may consume excessive amounts of food in a short period of time, such as a couple of hours, and these foods are generally things like biscuits, bread, cake, ice cream. There's a sense of loss of control during this time, and if the food runs out, they might raid the kitchen for more food. There's a real sense of a loss of control around this, and they feel unable to stop, and that leads on to feelings of guilt and shame and compensatory activities such as vomiting to cope with these emotions. Also, parents might notice large amounts of food going missing or finding empty packets in places hidden away. So the risks of bulimia nervosa, the frequent vomiting disrupts the can disrupt the electrolytes in the blood, and we need that affects how the heart is pumping. If they're vomiting for more than 3 times a week, regular blood tests at the GP surgery are needed to check the potassium levels. When the potassium levels are out of range, there's a risk that the heart stops pumping. Teeth can be affected, so the tooth enamel can become eroded from the acid in the vomit. So regular dental checks need to be in place. As I've mentioned, vomiting isn't an effective weight loss method. So people get caught in the self-defeating binge purge cycles. There can be bleeding from the esophagus, and this will come from the trauma to the esophagus in the vomiting, and also as a result of the acid in the throat. And this needs to be checked out by a GP. People with bulimia nervosa will have low self-esteem, sense of worthlessness and shame. They'll be feeling, very, very unhappy young people who are just struggling to try and manage their lives and using this as a way of coping. The less common we see it less common in adolescence is the swollen parotid glands. So this happens to people that are vomiting a lot. They may have quite a puffy kind of lower face from the parotid glands swelling, but usually this would need to be as a result of people vomiting a lot and over a long period of time.
Okay, I'm going to take over now and talk a bit about ARFID. So at the moment, we don't currently treat ARFID in our services. We're not commissioned to do so. But I'm going to talk a bit about it because we know that for a lot of parents, this is an issue, and finding help for ARFID can sometimes be quite difficult, as less is known about it as well. ARFID often occurs in the context of autistic spectrum condition. It's characterized by a person avoiding certain foods or certain types of foods. They might have restricted intake, or they might have restricted intake and also avoid specific types of foods. So it might be that a young person might only eat sort of 3 kinds of food, like potatoes, potato crisps, and pasta, for example, and they would not be having the sauce. They would avoid any other sort of protein to go with that. And the reasons for this might be that a person would find the taste or texture or smell or appearance of particular foods to be disgusting or intolerable. So people with ARFID are generally have heightened sensitivity either to taste or smell, or even sort of the appearance of food, as I mentioned. They might also only be able to eat foods at a certain temperature, or they might also only be able to eat a particular brand of food. For example, some young people can be specific enough that only a particular brand of crisps would be eaten, like Walker's cheese and onion crisps, but any other type of cheese and onion crisps would be unacceptable. And they'd be so sensitive that even if you hadn't shown them the packet, they might still be able just to tell from tasting the crisps. This leads to sensory-based avoidance or restriction of intake. Sometimes ARFID may also be due to a fear of aversive consequences, such as choking, vomiting, or feeling sick. So it might also be if someone is afraid of vomiting when they're eating, they might only sort of feel comfortable drinking food or drinking milkshakes that perhaps don't cause them to vomit, or that they think are not going to cause them to vomit. And it might be that a child or young person has had an experience where perhaps they had a virus and they were sick after a meal, but then eating becomes associated with the vomiting and becomes intolerable to them. So for a diagnosis of ARFID to be made, there needs to be nutritional deficiency and or very low weight, and the ARFID needs to impact quite severely on someone's daily functioning. So that would mean things like your young person perhaps not being able to go out to restaurants. They might avoid going out with their friends because they can't go to restaurants with them, or they may not be able to tolerate watching other people eat or smell the food in the school canteen, for example. So it can be really worrying, very worrying for parents, and it can be quite difficult to treat as well. So as I said, we're not commissioned to treat ARFID. If you are concerned about ARFID or think that your child might be suffering from this, we would recommend that you see your GP. And you could also ask for an ASC assessment if you think that there might be other things going on for your child as well. We know that Great Ormond Street Hospital has a specialist unit that treats ARFID, so you could ask for a referral to GOSH. And the Maudsley is also doing quite a bit of work on ARFID at the moment, so that that would be another avenue to try. Okay, so I'm going to talk a little bit about other types of eating disorders. I mean, these ones are really rare. And if you are worrying about some of these things, again, we would sort of strongly suggest that you go to your GP and ask for a referral to a dietitian. So just to quickly run through, pica is something actually normally associated with pregnancy. And if people are suffering from pica during their pregnancy, it's usually kind of limited to the pregnancy and tends to disappear once they've had the baby. But it can also occur in young people, and it refers to eating non-nutritive or non-food substances for a period of more than a month. And sort of things like it could be paper, it could be sort of other things which could also be quite dangerous. Rumination syndrome refers to the regurgitation, the spontaneous and involuntary regurgitation of food after eating. The times that I've actually seen this in our clinic is most often when someone is in the recovery phase from anorexia or bulimia, and not that I think more needs to be found out about this. We don't have a huge amount of information, but in my experience, I guess I wonder whether if someone has been vomiting for a long time, whether the body has got so used to that it associates eating with bringing up the food, and it becomes then a kind of something that the person just has no control over. Again, we would recommend you see your GP if you're worried about both of these things. Okay, so I think I'm going to just think a bit about what you can look out for as parents and carers. And we would always sort of strongly urge you to err on the side of caution if you're worried and go to your GP. We also know that, you know, you can trust your own parental instincts. If you're worried, it's much better to seek help earlier rather than later. And we also know that there's an idea out there that your child has to be extremely underweight to be referred to services. But this isn't actually the case, and we know that early intervention is better. Even if you are on a waiting list for treatment with us, support will still be provided, and so it's better to be in the service and waiting for FTAN, say, than to delay going to see your GP. A child doesn't have to be extremely underweight to be referred and accepted. So we do sometimes see young people in our service who are more or less a normal weight, but they have lost a huge amount of weight in a short period of time. And this is normally referred to as atypical anorexia, where body weight isn't particularly low, but weight loss has been extreme and dramatic. And we know that this is really taxing on the body, puts a lot of strain on the body, and also needs to be treated. So signs to look out for would be sort of new, unusual behaviors around food. For example, your child may cut food up into small pieces or push it around on the plate. They may start only eating the vegetables or making excuses that they don't like a particular food that they used to quite happily eat. You might also notice that they're becoming more and more preoccupied with healthy eating. So these can all be early warning signs of an eating disorder. So, you know, they might not want anything with sugar, and whereas before maybe they would have enjoyed some chocolate, you know, pudding after dinner, they may start not having those things. And, you know, you might think, actually, this is quite a good thing initially, because my child's healthy and perhaps sugar's not good for your teeth, etc. But we know that healthy eating, particularly for young people, is varied and moderate, and that young people need lots of food, they need lots of variety of food, and they often need the calories that comes in the kinds of food that we think of as a little bit less healthy. We also know that going on diets is dangerous. It's not particularly good for anybody, and it's particularly not good for young people who should really be gaining weight because their bones are growing. Other warning signs to look out for might be that your child makes comments that they think they're fat, or they might even ask you if you think that they are fat. Other times your young person may want to become vegetarian, they may want to become vegan, and in the context of other warning signs, this can also be significant. Watch out for your young person suddenly looking in the mirror more often when they haven't done that so much before. And I know that sort of lots of, you know, teenagers and adolescents will look in the mirror. That's very normal. But I think the thing you might also want to look out for is any kind of associated anxiety, very frequent looking in the mirror, or even avoiding looking in the mirror. That can also be problematic. They might be weighing themselves a bit more often. They might be pinching the skin or fat on their body, measuring their wrists or arms with their fingers or with a tape measure, for example. It's often, you know, pinching tummies. Tummies seems to be a particular part of the body that girls get really worried about, having a fat tummy. Fat tummy and fat thighs are the two things we tend to see the most. You also may notice your child's clothes becoming baggier. You may notice them wearing a lot more clothing, and this could be either because they just are a lot more cold because they've been losing weight, but it could also be that they are feeling very self-conscious about their bodies and they're trying to cover them up, or they're also trying to cover up the weight loss. You might also notice changes in mood, so they might be a bit more anxious than they used to be, or low in mood, but they might also be the disappearance of anxiety, as sometimes eating disorders can help young people manage their anxiety because it kind of blunts all their affects. So sometimes that's one of the things that sort of keeps an eating disorder going, is that the child kind of associates it with something that's helpful. The other thing that we would kind of also strongly sort of say is that if your child says they would rather die than be fat, or express other views that indicates that body image is very important to them, this should also be taken really seriously, as should it always be taken seriously that if a child expresses a wish to die, you kind of want to pay attention and keep vigilant about that. So other behaviors might be, you notice that your child's withdrawing, maybe spending a lot more time in their room on their own, keeping the door shut when they didn't do that before. You may see personality changes, increased irritability or snappiness, increased interest in food or baking or cooking food for other people, but not sort of partaking in any of it themselves. You may also notice their packed lunches coming home uneaten, or their money isn't disappearing from their card that they would normally use in the school canteen, for example. Likewise, if you see your child disappearing into the bathroom after meals or even during meals, or spending long periods of time in the bathroom when they haven't done this before, increased showering, for example, some young people will switch on the shower so that their parents can't hear the sound of them retching. These may also all be warning signs. Okay, and as Zoe said earlier, you know, someone who's been vomiting a lot may also have a puffy face, but you're unlikely to see this as a symptom sort of early on in an illness. Okay, so what to do first? So what to do if you notice some of these things going on? And it's very sort of natural to worry that if you talk about something like this with your child, that you fear that the thing you're worried about might actually come about, and that you'll plant an idea. But we would sort of say that the chances are that if you're worried, there probably is already something there, and not talking about it may create the conditions for it to continue, really. So we would say usually it is a good idea to broach the subject with your child after you've spoken to your young person's other parent first. So whether or not the other parent lives with you, or you know, it might be a step parent who's living with you, for example, you want to have that conversation with that person so that you can make sure that you're presenting a united front. So we know that eating disorders are experts at splitting parents and slipping through the gap. So, for example, you know, a young person might say, you know, oh, I've already eaten with dad, or dad says I don't have to have this, and you know, kids will often be very good at exploiting those kinds of situations. So you'll want to kind of be having conversations with your partner to get on the same page and to be in agreement about what's being said and about what you're putting in place to try and tackle the eating disorder. We would encourage you to keep an eye on what your child is eating, and sort of keep a surreptitious eye, so that you sort of have a good idea of what their intake is in a day. Open up space for your young person to talk to you about their worries. Let your child know that you're concerned, that you care about them, that you're there to help, and you're available to listen. And it might be that when you do kind of broach the subject with your child, that they don't want to talk about it. And that's okay. The main sort of the important thing here is really to kind of show that you've noticed, that you care, that you're not going to ignore it, and that you know, if they do need to come to you, that you're going to be there. And you may have to repeat that message several times over, actually, without obviously, you know, pushing so far that your child kind of withdraws even more. And then if your young person does talk to you, try not to rush into reassuring. So it's very tempting to kind of try to say everything's going to be okay, and don't worry, you're not fat, and this is what we're going to do. But try not to dismiss their fears, and try not to rush to solutions. So we know that young people have told us often that you know, talking to their parents is most helpful when parents listen and just reflect back what they're hearing about their feelings. So, for example, you know, if your young person was to say to you, oh, I'm really fat, or I'm fatter than all my friends, simply denying this is not necessarily going to reassure them. Rather, you want to kind of be responding to the emotion or the feeling behind that by saying something like, you know, I'm really sorry that you're struggling with these thoughts, these horrible thoughts. And you might want to say these horrible untrue thoughts. So you are getting the idea in there that they're not true, but you actually are responding to their feelings. So I hear that these thoughts are making you miserable, and I'm here to support you through this. You'll obviously, you know, find your own words, but that's kind of the general gist of it. You can also have a look at the BEAT website for information and supports. Look for lots of different resources that are going to be helpful. Do a bit of research. Okay, so what to do next? So we would say start to supervise meals. So if you are sort of noticing that your young person, you know, isn't eating enough, and you realize actually we need to do something about this, accept that your preferred parenting style may need to change. So you may have been the kind of person before that sort of likes to include your child in decision making and negotiate with them, which is all really lovely and good sort of parenting techniques. We know that some of those techniques are not going to be hugely effective if someone is struggling with their eating. So it might be that you kind of need to go back to a position where you are being a bit kind of a bit firmer really about meals and what your young person needs to eat. And if they've lost a lot of weight, they're going to need a lot of food to weight restore. So this would probably look like around 3 quite large meals, including pudding, or 3 normal sized meals and 3 snacks spread out through the day. So, you know, you'll kind of judge for yourself what might, you know, work best for you and your family. And we know also that it's easy to panic when you're feeling really worried about your child, and you might think, well, I don't know how much food this is. However, it's likely that you've been feeding your young person very appropriately up to this point. And it's just a matter of kind of connecting back to what you know about what your child needs. Try as much as possible to stay as calm and compassionate as you can. This is really important. So share your worry with your partner, with some friends, with people that you can trust, and do what you need to support yourself so that when you are in front of your young person at the meal table, you can present a calm and compassionate approach. Of course, we would always say, you know, when you're feeling anxious, you are likely to sometimes lose your temper or shout. We would say, don't beat yourself up if this happens. It's absolutely impossible to be a perfect parent. No one could manage that. So we suggest in that case apologizing for the outburst or for shouting, but never to apologize for being firm about eating. The other thing that we would say is probably a good idea if you're worried that your young person isn't eating their lunch or is not eating anything at school. You could contact school and find out what they might be able to put in place to support you. So some schools might be willing to sort of have a teaching assistant or somebody who works there, someone from their pastoral support team maybe, who would take your child into a classroom and eat with them. Some schools would not be able to offer this though, and if they couldn't, you could sort of ask them if you could come in and take your child out at lunchtime to ensure that they are having their lunch, and then they can go back in. They can go back into school when they've had it. Some children don't want their parents to come into school, and obviously this could be sort of embarrassing for them. So what some people have done is they take them out to the car, and then they go back into school when lunch is finished. I mean, the general idea of this is that you kind of want to convey to your child that not eating is absolutely not an option. It's non-negotiable. It's something that needs to be done. Food is medicine, and you want to kind of make sure that your young person knows that you're not going to give up. At the same time, you want to also be attentive to their distress and be compassionate about how they're feeling. So a young person who's struggling with their eating is going to be feeling quite miserable. They're going to be feeling very anxious, and you want to be able to kind of respond to their feelings. If your young person shouts, screams, refuses, runs to their room, as I've said before, try to stay calm and then try again. So it might be that you need to put time out in. If your child's sort of having a bit of a meltdown at a meal, you might say something like, you know, this is obviously really tough. Really sorry it's so tough for you. We're going to take 5-minute time out and then we're going to try again. So your child's going to get the message that you are concerned, you care, you understand that they're feeling awful, but you're not going to give up on making sure that they have what they need. So as I said before, food is medicine, and keeping this idea in mind will help everyone stay on track. So, you know, you wouldn't allow your child not to take their life-saving diabetes medication or to refuse any other medical treatment if it was needed. And it's exactly the same with food. And if you are doing these things, and it will become apparent very quickly if your child's struggling. So don't worry that your child isn't underweight enough. As we've said before, early intervention is key. And so we would encourage you, if you're really struggling, to go to your GP, find all the resources that you can, do some research, look on the BEAT websites. Lots of our parents say they find BEAT extremely helpful. We also recommend Eva Musby videos. So if you go onto YouTube and just type in the search bar, Eva Musby, lots of things will come up. So there's one video that's really lots of parents find very helpful. It's called bungee jumping. So we recommend that you go and have a look at that. And you know, lastly, but most importantly, really, look after yourself and seek support. So we know that looking after somebody with an eating disorder is tough, very hard to do. It takes its toll. And it's tough to do it alone. So do try to make sure that you rely on your support networks as much as you possibly can. Okay, so a little bit about what not to do. I probably have touched on some of these, but I'll just go over a bit again. So as I've said before, when people are worried, they often go into fight-flight mode because you've also got kind of stress hormones coursing through your body. So cortisol and adrenaline actually causes physiological symptoms in your body. And sometimes when you're really, really stressed, you might feel that you've got less control, resort to shouting in the heat of the moment. So try to pay attention to your own coping style and what's going to be helpful to you to do what you can to approach the situation calmly with your child. Try not to disagree with your partner in front of your child for kind of the reasons that we've touched on before, that eating disorders are very good at splitting. You want to be able to present a united front. So your child needs to experience you both as safe and containing and kind of knowing what to do. If you become distressed and agitated in the face of your child's distress and agitation, that's just going to escalate. It's going to escalate and probably make things worse. The other thing that we would recommend is not trying to reason with your child or kind of have an argument with them about why they need to eat what you're telling them they need to eat. Because of the cognitive dysregulation, they are not in their rational brain. And so there's no point really. So we would find just kind of being very concise, repeating the same reassuring sentences over and over. For example, things like, this is what you need to have, we know this is safe, we're going to try again, pick up your fork, etc. And try not to get into arguments about how much oil is in a particular food or, things like that. Also, we would also suggest, while everyone's so distressed and worrying about food and eating, that you pick your battles. So now might not be the time to insist on rooms being tidy or chores being completed, for example. It's also can be quite tempting to talk to your child about the impact on you and how they're disrupting the whole family and how, can they eat for you? Try not to do this because this kind of only sort of adds to the guilt they're feeling, which are going to add to the cocktail of emotions, which is going to sort of probably make them want to rely on the eating disorder even more. So yeah, I think also let siblings know that you're handling the situation. Be as open as you can with siblings as well. They will always know what's going on. So it might be very tempting to sort of think, I don't want to worry them. And so I'm just not going to speak about this, but they will pick up what's happening in the house. They'll pick up on the emotions. And often it's a lot scarier for other children in the house to kind of sense emotional atmosphere and then not to know what that's about. So we would say, try and sort of share what's going on. You can also ask siblings to help by sort of providing distraction techniques or being a friend to the young person with the eating disorder, but don't let them get involved in telling their sister or brother to eat. So, your young person with the eating disorder is going to need someone in the house that isn't associated with being made to do something that's very difficult for them. And so if their sister or brother is someone that they can go to for support, that is going to be hugely helpful. And they can also be very good at providing distracting techniques, such as playing games at the table, the dinner table, for example, which is something you might not normally do, but anything that's going to help a young person struggling to eat is a good thing to do. And finally, I would say, very importantly, try not to go on diets or talk about your own body negatively in front of your young person. You want to kind of portray, that self-worth is based on your person and not on what your body looks like. Okay, Zoe, I'm going to hand back over to you to talk about when it might not be an eating disorder.
Thank you. Okay, so sometimes it's quite, the symptoms can overlap a little bit, but not all problems with eating are mean the young person has an eating disorder. It's worth considering that your child's eating difficulties might be something different. For instance, if a young person or someone is low in mood or anxious, that might also cause them to lose their appetite and lose weight. So in these cases, it's important to treat the underlying cause rather than the eating. So there could be systemic factors going on which are distressing the child, such as not wanting to go to school for some reason, or some bullying or some friendship issues. And for those situations, it's important to address that with the child and with the school, really, rather than to treat the eating. There's also lots of information on social media, and eating disorders are often glamorized on social media. And somebody that might be a young person that might be feeling quite lost or uncertain or lacking in confidence or low self-esteem might notice that the person with an eating disorder has a lot of attention, has a lot of validation. And in these cases, there's a risk that that weight loss and the distress around the emotions could tip into an eating disorder. It's important to treat, as I said, the initial presentation, really, such as the low mood or the anxiety or the distress about school. Going straight to treating it as an eating disorder or anorexia might make it worse. I think, was there anything else to add to that, Sean? I think that was basically what I was thinking about. It's kind of about them feeling validated as a person and not getting the validation from the eating disorder. Treating them as if they have an eating disorder can perpetuate those feelings and encourage them to keep losing weight, to keep the attention. And that's really worrying, because if they continue to lose weight, then it can tip into the anorexic symptoms that we saw that we talked about earlier on, you know, with the Minnesota studying that it can trigger those thoughts with a significant amount of weight loss. When your child seems unwell, so spending unhappy, spending a lot of time, spending time with the child away from meal times. So providing some positive attention and interaction, doing something, you know, enjoyable together is important, and then reducing the attention provided from an unhealthy interaction, such as you know, the attention around food and the weight loss. So trying to turn it around and notice the positives, and spending positive time together is really important in these situations.
Okay, so I'm going to talk a little bit about the evidence-based treatments, and the main treatment that we offer in our service is the first-line treatment that's recommended in the NICE guidelines, and that is family therapy for anorexia or family therapy for bulimia. And these are manualized family-based treatments, and they are designed to support parents to refeed their young person. So it consists of 3 phases. In the first phase of therapy, we support parents to help their child weight restore. So this is really important because, as we've kind of said before, the physiological effects of the weight loss will be impacting on the brain. And we know that that's going to make the restricting and losing weight even worse. So in order to reverse the effect on the brain and to kind of have a chance of getting your child back to thinking a bit more rationally and being able to choose healthy eating for themselves, you need them to physically recover. We know when someone's very underweight that individual work is not going to be effective due to the cognitive dysregulation of a starved brain. So if a person is malnourished, they're not going to be able to change their thinking. We know that individual therapy may be effective for anorexic cognitions when a young person is closer to full weight restoration. We also know that some families feel that when they're offered family therapy, this implies that they're to blame somehow or that they need to be fixed, and we absolutely know that this is not the case. Eating disorders impact on families and they cause distress. And the family work is designed to address the impact of the eating disorder on the family. We know that it should always be a collaborative piece of work, and you should feel that your therapist is working alongside you to put changes in place that you would want to make. So we know that you are the expert in your own family, and you will know your child better than anybody else. We also know that, as therapists, we've worked a lot with eating disorders, so we want to kind of achieve a sort of a collaboration between, we will give you the advice and the things that we know has worked in the past, or things that you can try, and the therapy sort of offers a space for you to be coming back and letting us know how that's working. Perhaps things need to be tweaked or shifted a bit, because all families are unique, and different things may work for different families. So in phase 2 and 3, we'd be moving on to helping a young person to get back to independent eating and to start taking a few risks. And we'd also want to start addressing some of the relational dynamics in the family that may have suffered as a result of the impact of the eating disorder. So it may or may not be that there were some struggles in your family before the eating disorder started. This is normal. Lots of families, go through difficult times. This is probably not the reason that your child developed an eating disorder. We know, as I've said before, that eating disorders come about in all sorts of different families. There's no research to indicate that any kind of family constellation or separation or anything like that causes eating disorders. So therapy is really about trying to help you to get back to addressing whatever might have happened as a result of this really sort of massive, monumental thing that's happened in your family. So, you know, we don't want you ever to feel judged. It may sometimes be that those feelings come about in therapy. We would be hoping that, you know, that would be something that you would be able to talk about. Therapy can sometimes be challenging because it's, you know, sometimes your young person may not want to come, for example, because, you know, gaining weight is very distressing and they are going to be weighed at every session, for example. It may sometimes be challenging because, you know, we're opening up conversations that perhaps, you know, all of the family's been avoiding in order to avoid distress. So, you know, you're already struggling with the eating disorder, and then, you know, difficult things are coming up. So it's, you know, it's understandable that therapy doesn't always feel, you know, the therapy can sometimes feel a bit difficult. We also know that eating disorders can often occur as a coping mechanism for managing difficult emotions, as it sometimes blunts them. So sometimes it can feel like a bit of a battle to get your young person well. So as I said, in phase 2 and 3 of FTAN, or of FTBN for that matter, the focus is on getting back to normal, helping your young person to get back to developmentally appropriate tasks, and hopefully to get to a place where, you know, they're not going to suffer from an eating disorder again. We know that people can and do recover from eating disorders. So, you know, that's a hopeful message. The other thing that we often ask parents to do, which, you know, is really difficult for families, and we, you know, absolutely understand the challenges involved in this, but you may need to take time off work to do refeeding effectively, and we often recommend taking a young person out of school if they're struggling to wait, restore. So we usually find that sort of giving it your all for a shorter period of time is often more effective than kind of trying to spread it out over a longer period of time. Okay. Zoe, did you want to talk about other treatments?
Yeah, so we have, as we've said, that the family therapy is the first line treatment. The second line treatment to address distorted thinking or beliefs, or for older adolescents where weight may not be too low, is CBTE. So this generally needs a level of and a degree of motivation to recover. And that's why it's not used as the initial first line approach, because the children and young people with anorexia and bulimia often don't want to recover initially. They're frightened of letting the eating disorder go. It's you know, it's there as a constant kind of for them, and it may not be a positive voice, but it often starts off as quite a positive voice, and changes into a kind of a bully after that, really. But they're frightened to let it go. They don't know what life is like without it. So we're working with you know, young people that are frightened of recovery. So CBT works a lot more effectively with somebody with a bit of motivation, or for an older adolescent. So we have a first line approach that we also use is the psychoeducational parents group. So at the moment, the Beat charity are commissioned from us to provide that for parents, and that's a group they can go into, which gives them lots of information and ideas, and they can it's done online, and they can meet other parents that are in similar positions and share helpful thoughts, really, with each other. We have a new group starting called Prosper, which is a group with strategies to support young people with anxiety, help them with coping mechanisms to manage distress. And we have a hunger understanding group, which can be done on an individual basis as well, and that's works really well with the young people as well. and gets them thinking about their bodies and the other functions of their bodies, and supports them in that kind of way. And yeah, a body image group, which again helps young people look at, you know, the useful functions of their body and what their legs are doing and what their, you know, what their bodies are able to achieve other than kind of the way they look, and those can be quite useful as well. I think it's also probably worth mentioning that, you know, sometimes young people are too unwell to remain recovering in the community. It does happen sometimes that children have to be admitted to hospital for treatment there if they are just too unwell to remain safe in the community. And, you know, that shouldn't be seen as a failure or anything other than the severity of the illness, really, and that's where they need to be most safe to aid their recovery. But we, you know, obviously it's preferable for young people to stay at home to recover. So treatment for bulimia. So according to the NICE guidelines, again, first line is FT for bulimia. So it's family therapy in the same way it's family therapy for anorexia, but this focuses on supporting them to break the binge and purge cycle, so to stop the vomiting. Sometimes CBTE, which is cognitive behaviour therapy for eating disorders, is used, but this again needs motivation from the young person. A psychologist would be unable to work with somebody who was kind of really lacking in any motivation to recover at all. And how to refer, so that parents can refer their own child, but if they do that, they will need to have made a GP appointment as well to get the child's BP checked, the height, the weight, have an ECG done, so that we have some other kind of medical information that we need to kind of piece it together a little bit. Obviously the height as well, I said height and weight, yeah. So, and also GPs can obviously refer into us as well.
I think, yeah, it's probably also worth mentioning here that in terms of sort of access and waiting time directives, if you do refer your young person to us, depending on the severity, so for urgent referrals, we will see you within 5 days. And for routine referrals, we will see you within 2 weeks for assessment. So that refers to assessment times. Unfortunately, we do have sort of longer waiting lists for treatment, but we do, you know, we will support you in other ways when you're within the service. So, you know, we offer physical health clinics where we can sort of check on your young person's weight and blood pressure, things like that, if we're really worried about them and if they're losing weight. So as we've said before, you know, don't hesitate to seek advice, go to your GP and speak to someone if you're worried, or call us up. Other resources, so there is a digital pack which will be sent out to you after the presentation, and some of the things that we've mentioned about resources such as Beat, Either Must Be, and some books and sort of quite a few other things that you can go and have a look at will be in that pack. So we hope that that's going to be helpful for you, and we're really pleased that you've joined us. I think we did have a few questions that came in before the presentation. I do believe that we've answered most of them, having gone through the presentation. I very much hope that that's the case. I know that one person asked us a question about a 6-year-old who kind of I think was struggling to get her 6-year-old to eat. And I would say in that situation, we are less of an expert with younger children because we don't see children under 10 in our service. But however, I would be thinking that sort of addressing difficult eating with a 6-year-old would probably be different to addressing an eating disorder with an adolescent, for example. So I would say at that age, you really kind of don't want to be getting into emotional battles with your young person about food, because we know that sort of kids pick up quite quickly on that kind of charged atmosphere, and then that becomes something that they know is going to cause a reaction. And so I would sort of suggest being very relaxed with a 6-year-old about what they're eating. A lot of 6-year-olds or young kids find it very difficult to eat 3 meals a day, and so they might be more comfortable eating snacks. I would say if you have quite a relaxed sort of attitude to what your child eats, as long as they're kind of getting what they need in a day, then you could always offer choices or smaller meals throughout the day, and try to be sort of calm and matter of fact about food, and sort of take the emotion out of it, really. So hopefully, if you were the one that sent that question, I hope that's helpful. However, if you are really worried and you kind of think you need a bit more help, then by all means go to your GP, ask for a dietetics referral. So was there anything else that perhaps came in as question-wise that we haven't managed to address in the presentation?
Not that I can think of, Sean.
I think, actually, there was a question about, someone sent in a question about emetophobia. I think the young person was also quite worried about it for themselves, and I would say they're definitely go and see the GP. And what you would probably need is a referral to some kind of CBT, which addresses sort of the thoughts, feelings, behavior pyramid. So, that idea that, negative thoughts are causing you to feel bad, and then the bad feeling kind of influences how you behave. And you want to start addressing some of those thoughts and start to take sort of small risks. But a CBT therapist would probably be the best person to help you do that.
Yeah, it's about making kind of small, achievable steps forward, isn't it? And it's less about eating disorder, really. It is more of an anxiety-based presentation. So yeah, CBT.
Yeah, absolutely. Well, thank you so much for joining us on this evening. We really hope that this has been helpful. Please do give us some feedback, and we hope you enjoy the rest of your evening.